Welcome back, warriors. In this video we are going to review malabsorption. Remember, in malabsorption we have inability to absorb fat, and this will lead to high fat in the stool. And all the symptoms are related to this fact. So we have the fat soluble vitamins, the ADIC group, K, E, D, and A, ADIC. So for K we have prolonged PD and PTT. For vitamin E we have neuromuscular symptoms and hemolysis. Let the E helps you with that. For vitamin D, we all know the calcium and magnesium issues. And for vitamin A, the blindness. We have night blindness and it can lead to complete blindness. For the fat, remember fat has high calories. So when the fat is lost in the stool, this will lead to weight loss. So remember, malabsorption to look to the vitamins and its related symptoms and signs and labs. And for the weight loss to guide you through your question. And remember guys, the stool will be described as fatty, oily, greasy, foul-smelling, and floating. This is the definition of steatorrhea. Steatorrhea means that we have a stool that has a high fat in it. The causes are chronic pancreatitis, celiac disease, Whipple's disease, and tropical sprue. We discussed chronic pancreatitis previously in previous video. We will discuss in this video celiac disease. Just remember that the iron dude, let it help you to remember that the iron is being absorbed in the duodenum, and the terminal ileum, because it's the B12, all the B's, B1, B2, 3, 12 is the terminal of the B's because it has the higher number, B12, there is no B13. So remember, B12 is the terminal and it is absorbed in the terminal ileum. Now let's go to celiac disease. What I want you to remember in celiac disease is to remember there is an inflammation. It's related to reaction against gluten. So remember, wheat, rye, gluten, and barley will cause an inflammation, and this inflammation will involve antibodies. And the end result will be malabsorption because it's autoimmune disease related to the gastrointestinal tract. Now, the manifestations are related to this. So we have the ADIC vitamins deficiencies and its related manifestation. We have fat malabsorption and weight loss and diarrhea. We have bloating and pain because of the malabsorption of the food. This will cause gas formation and will result in pain. And also we have osteoporosis risk because of the lack of vitamin D and calcium absorption in the intestines. Now, for the other manifestation, we will have iron deficiency. And usually it will be related not to bleeding. So when you see patients who has no history of bleed and has iron deficiency, think of celiac disease. Also disturbed LFTs, liver function test. And there is a unique feature of the skin. It's the papulovesicular rash, dermatitis herpetiformis, we'll discuss it later. And autoimmune diseases, other diseases like thyroid and diabetes. And usually it is diabetes type 1. So it's very important to remember that the International Society of Pediatrics and Adolescent Diabetes recommends to screen patients with diabetes type 1 for celiac disease. And for the rash, remember it's sporadic and it's vesicular and on the extensor sites. Now for the bloating and diarrhea and the weight loss, they might be absent in your case. So remember, when you see the manifestations before and in the absence of diarrhea and bloating, you can still have celiac disease. So keep a low threshold while solving questions related to celiac disease. And celiac disease is a very hot topic and it's underdiagnosed in the clinical practice. So usually every exam contains 1 to 2 questions related to celiac disease. So it's very critical to master this topic. Sometimes they might mention patients with autoimmune disorders and especially hypothyroidism and is not responding to increasing of L-thyroxine doses. So think of celiac disease. The patient is not responding because of malabsorption to the L-thyroxine that he is taking. So when you see a hypothyroid not responding to L-thyroxine and yet you are increasing the dose and no response, you screen for celiac disease. For the diagnosis, remember it's an inflammation related to gluten, barley, rye, and wheat. So we have antibodies. So for the antibodies, they are usually annoying. We have 5 antibodies. The most specific and sensitive one is the IgA tissue transglutaminase. So remember, the IgA antibodies are found in mucosal membranes, and we have here, it's related to intestine, so we have mucosal involvement, so remember it's IgA. So we have the IgA endomysial antibodies, we have the IgA tissue transglutaminase, the most specific and sensitive one, and the most important one. If they tell you what would you find next, and they present patient with celiac disease and they put all the antibodies, you pick up the tissue transglutaminase, the IgA one, and also the IgG tissue transglutaminase, and they are the IgA and IgG deaminated gliadin peptide antibodies. All will be positive. But remember, again, the most important one is the IgA tissue transglutaminase. And remember, IgA, it's A because it's related to mucosal involvement. This is very important. And always remember, if you have a typical case of celiac disease and yet the IgA antibodies are normal, remember the tip that IgA deficient patient, they might have normal antibodies and yet they might be celiac disease positive patients. So remember, the tip is that they might mention in the history that the patient has developed anaphylaxis in reaction to blood transfusion. This will hint you to IgA deficiency patient, and hence you will have a negative IgA antibodies while screening these patients for celiac disease. Once your patient has a positive antibodies, or you are suspecting celiac disease in IgA deficient patient, you need to do a scope and biopsy to confirm the diagnosis. It's a must, the biopsy, and to reveal flat villi. It's a must because you need to rule out lymphoma of small bowel. This is a complication to celiac disease, and this is critical. All the patients, regardless they have positive antibodies, you do the biopsy regardless of, it's to rule out lymphoma and to confirm the diagnosis. For the treatment, remember, you put the patient on a gluten-free diet, and the most common cause of relapse is the patient non-compliance. If the patient is compliant and yet he is not improving, you need to rule out malignancy again, and you do scope and you retake biopsies. If that was the case and the patient has no malignancy, you can add steroids to the treatment, because remember, there is an inflammation here. Going back to the skin manifestation of celiac disease is the dermatitis herpetiformis. It's seen on an extensor. It's a pruritic papillovesicular lesions. The treatment is to give dapsone because of its anti-inflammatory effect and not as antibiotic. Thank you guys for watching, and hope this was a helpful review. Please subscribe and support the channel. We will upload more videos for you in the future.